You're listening to Clinical Conversations. This is Joe Elia. We have an interview about salt this time. But first, the week's top news stories from Physicians First Watch, read by editor Amy Herman.
Thanks, Joe. First, the FDA is requiring a boxed warning for the asthma and allergy drug montelukast over concerns about the risk for mental health side effects like suicidal ideation. The label already includes a warning about such risks, but after reviewing the evidence and meeting with experts, the agency decided that a stronger warning was needed. Montelukast is sometimes sold under the brand name Singulair. Next, the U.S. Preventive Services Task Force updated its guidelines on screening for hepatitis C. The group now says that all adults aged 18 to 79 should be screened at least once, regardless of their risk status. And in coronavirus news, COVID-19 emerged in many states across the U.S. this week, and at least 11 deaths were confirmed. Most of the fatalities were linked to a long-term care facility in Washington state. In addition, the CDC expanded its criteria for testing so that more people could be tested, and researchers reported that the secondary attack rate among household members of patients was over 10%. Next up, a large study among U.S. health professionals and a meta-analysis find that eating eggs is not associated with higher risk or lower risk for cardiovascular disease events. An editorialist called the findings, quote, convincingly null. And finally, the FDA warned that patients should not use unapproved methods for cleaning their CPAP machines. These include using ozone gas or ultraviolet light. The agency noted that the concentration of ozone required to kill bacteria is considered unsafe for humans. And that's it for this week. Stick around for Joe Elia's latest clinical conversation.
Salt and sodium intake have challenged medical researchers for generations. What seems indisputable is that too much salt is not good, especially in hypertension. After that, things get fuzzier. National advice on restricting salt intake has been challenged by findings that restricting salt too much can increase cardiovascular risk. Professor Feng He and her colleagues looked at the question of whether existing studies showed a relation between reductions in dietary sodium and changes in blood pressure. They performed a meta-analysis of 133 studies comprising some 12,200 participants. Those studies all randomly allocated participants to either reduced sodium intake or usual and thus higher intake. All studies collected 24-hour urine sodium data to estimate those intakes. In short, they found a dose-response relationship between intake and blood pressure change. Professor He works at the Wolfson Institute of Preventive Medicine at Barts and the London School of Medicine and Dentistry, Queen Mary University of London. Welcome to Clinical Conversations, Dr. He.
Thank you. Thank you for having me.
You have been researching salt for about 25 years. What have you observed about the research over that time? Have you changed your mind about the effect of dietary salt and health and blood pressure?
No, I haven't changed my mind, because when you look at the salt reduction as a public health strategy, you need to look at the totality of evidence. You need to look at all different types of studies, including studies in population, like epidemiological studies and the population-based intervention studies, randomized trials in humans, animal studies, and also physiological studies. So all of these different types of studies have consistently shown that dietary salt intake is a major cause of raised blood pressure. And also, salt intake is also an important determinant of the increase in blood pressure with age. I remember when I was in the medical school, we were taught that systolic blood pressure increases with age. This is normal physiological phenomena. But later on, scientific evidence have clearly shown that this is not normal, and a high salt intake is an important contributor for the increase in blood pressure with age. if you look at the societies, now, there are still some societies, isolated tribes. They don't have added salt in their diet. And that's like our human ancestors. And their blood pressure, their average blood pressure for adult population is only 90/60 millimeter of mercury. And their blood pressure do not increase with age. And their population do not have a cardiovascular disease at all. And you may say, people in the isolated tribes, they die at a much younger age. However, if you compare those isolated tribes with the Western population with the same age group, in the Western societies, there are so many people suffer or die from cardiovascular disease.
Yeah, the fact that the research is ongoing tells us that not everyone believes that the results are final yet. Would you agree with that?
No, actually, you never get a final results because you know what? For any dietary factors, it is extremely difficult to do. Using gold standard method to do a randomized outcome trials. For example, if salt reduction, you have to randomize many thousands of individuals and on the high salt and the low salt diet and keep these two groups for many, many years to see whether there's a difference in cardiovascular outcome. The problem with this is, firstly, there's overwhelming evidence to show that a high salt intake is harmful to human health. It's unethical to put a group of people on a high salt diet for so many years. Secondly, there's on the lower salt group, in the current food environment, it is extremely difficult for individuals to keep the lower salt diet for many, many years. That's almost impossible in the current food environment.
Yes.
And thirdly, this nowadays salt reduction, for many countries have started salt reduction initiatives. Like the government have this program, and NGOs, health professionals in the media, even in the control group, you wanted them to be on the high salt diet. They received all of this message from the media, from the radio, from television, from newspaper. They will lower their salt intake too. So in the end, you wouldn't see a difference in salt intake between the two groups, and there's a severe contamination between the two groups. So it's difficult to do such outcome trials, to keep two groups under their low and high salt for many, many years.
I see. Is it possible to lower salt intake too much?
No, this. If you look at this isolated tribes, they don't have added salt to their diet. There's lots of food, like some of the food naturally already has sufficient salt in their diet, like meat. And our ancestors, they do not have added salt. But they live healthily, and then now even in the isolated tribes, they still live in the lifestyle, like all in the hunter-gatherer lifestyle. They don't have added salt. Their salt intake, as measured by 24-hour salt excretion, is less than 1 gram per day. It's much lower. They live perfectly well. Yes. They don't have cardiovascular disease. So in our current food environment in the Western societies, there's no way you could reduce salt intake to such a level.
Okay.
And currently, in most countries, the average salt intake is about 10 grams per day. And the WHO recommended level is 5 grams per day.
Yes.
And for the US, it's 6 grams per day. And for the UK, it's also 6 grams per day for the general population. However, for the US, and there's for almost half of the population, the target actually much lower, is 4 grams per day. For example, individuals with high blood pressure, people of African origin, and also people with kidney disease, because they are and the people with high blood pressure because they are at increased risk. So their target should be even lower to 4 grams per day.
Well, what prompted you and your colleagues to undertake this meta-analysis?
This meta is updated meta-analysis. I don't know whether you know, we have published a meta-analysis in 2013, published in the same journal, BMJ. At that time, what we look at is a modest reduction in salt intake and for longer duration as currently public health recommendation, for example, from 10 grams per day to 5 grams per day, to see whether that reduction has significant effect on blood pressure. What we showed at that time is a modest reduction in salt intake for a longer term, duration over a month or longer. There's a significant effect on blood pressure in both hypertensive and non-hypertensive. So this new study, why we updated is that this not only we updated, included many more trials, and also this focus to look at the dose-response relationship between salt reduction and blood pressure, and also look at the duration, whether the duration has any effect on the effect of the salt reduction of blood pressure. So this time the inclusion criteria is different. We basically included almost all of the salt reduction trials with 24-hour urinary sodium measurement. So with these many studies, we have shown a clear dose-response relationship. So the greater the reduction in salt intake, the greater the fall in blood pressure. So the current public health recommendation is from the current level of approximately 10 grams per day to the recommended WHO recommended level of 5 grams per day. That will have a significant effect on lowering blood pressure. However, if you lower salt intake further down to 3 to 4 grams per day, the effect on blood pressure would be bigger. So there's a clear dose response. So the greater reduction of the intake, the greater the fall in blood pressure.
So you found that lowering salt intake is good for blood pressure, even among people without hypertension. But you were careful to limit your findings to blood pressure and not cardiovascular disease or other things.
This is a very good question. And because, as I mentioned earlier, it's extremely difficult to do a randomized trials to look at cardiovascular outcome. Hardly any trials have looked at the longer term salt reduction on cardiovascular outcome. And having said that, I do not know whether you have seen a previous meta-analysis we published in the Lancet. Basically, because there is no sufficient number of studies look at the long-term salt reduction on cardiovascular outcome, what we had to look at in that meta-analysis is to look at the trials that the aim was to look at the blood pressure. However, after the trial completed, the researchers followed this participant up many years after the trial. So even that type of studies, not exactly in the real long-term outcome trial, but still that type of study have indicated that a reduction in salt intake has a significant effect on reducing cardiovascular events.
But the question that you asked was a simpler one. And the other, in addition to lowering blood pressure across the board, you found that studies that were of a short duration, for instance, 2 weeks or less, didn't show the effect as much as those studies that were longer term. Is that right?
That's right. That's right. This study shows the dose-response relationship is much stronger in the longer-term trials compared to the short-term trials. So it's likely that the short-term studies have underestimated the impact of salt reduction. And the problem with looking at the duration, look at the effect of duration on the effect of salt reduction is quite difficult because at the moment, not many longer-term trials, salt reduction trials, only a few trials have a duration lasted 6 months or longer.
Yes.
The the problem is with this type of trials, initially the people achieve the reduction in salt intake, but with time, the current food environment, it's impossible for individuals to keep the lower salt diet for long term. So by the end of study, a few years, they already salt intake gone back to the to higher level.
Yes.
So that's why longer term study you can see a greater effect, but then the longer term study have not achieved a greater reduction in salt intake. So if you really want to look at the long term effect, the duration, the effect duration on the blood pressure lowering effect, we should have longer term trials, but the individuals keep on the low salt diet throughout. Yes. And then you have multiple measurement of blood pressure throughout. So the only study you can show this is the DASH sodium study. I do not know whether you have heard of DASH sodium study. In this DASH sodium study, compliance is perfect because it's a feeding study. Mm-hmm. All of the food and the drinks are provided to the participants.
A footnote. Dr. He wanted to add this observation after her comments on DASH. Quote, countries that have achieved a reduction in salt intake for several years, for example, Finland and the UK, have demonstrated a much greater impact of salt reduction on population blood pressure, end quote.
So that's individual can keep the lower salt diet over the whole study duration. That study have shown that with longer duration and the effect of salt reduction on blood pressure is bigger compared to short-term study.
The effect seemed especially stronger in older people, non-white populations, and those with higher baseline systolic pressures.
That's right.
Okay. And so that is I guess that's the population, it would seem, that would have been exposed, especially older people, to this kind of food environment, as you describe it, that is going to have loaded their bodies up with salt over many years, isn't it?
That's one of the reasons, but there's other reasons, like in our human body, we have this hormonal system, like a renin-angiotensin system. Mm-hmm. And this system is actually maintaining our blood pressure. And because for individuals with older age and people of African origin and also people with a high blood pressure, their renin-angiotensin system is suppressed. Uh-huh. And so this usually, like young people, if you reduce your salt intake, the renin-angiotensin system react, and then there is an increase in plasma renin activity, increase in angiotensin too. This is like the compensatory mechanism to maintain your blood pressure. Okay. For elderly and for people of African origin, and also for those with high blood pressure, this system is not as active as young people or compared to their counterpart like white population or people with normal blood pressure. That's one of the mechanisms for those subgroups have a greater fall in blood pressure for a given reduction in salt intake.
What do you think these findings mean for people who are skeptical about over-restricting salt intake? There have been some researchers in Europe, I know of one group, that have data saying that over-restriction of sodium leads to greater cardiovascular risk.
Yeah, I'm fully aware of these publications, and we have published several papers, and there's lots of debate about this. And the problem with that study is there's a severe methodological problem. For example, that study measured salt intake using spot urine. Spot urine is measured sodium concentration. For example, if I have just have 2 glasses water now, 2 hours later I collect spot urine. My sodium, if you measure my sodium concentration in that spot urine, is much lower because that's diluted, and also this is spot urine. They convert spot urine sodium concentration to 24-hour urine sodium concentration to estimate the individual daily salt intake.
I see.
They use a formula to convert this spot urine sodium, 24 urine sodium. This formula included age, gender, sex, height, weight. We all know age is important determinant of any health outcome or death, and also age also associated with salt intake. And also the other factor, gender and body weight and the 24 urine creatinine. All of these factors are important confounding factor because they both relate to salt intake and also relate to health outcome. So this study, they reported J-shaped. They can't control such confounding factors.
I see. Okay.
And so there's a lot of methodological, but that's on a measurement error. We call it a measurement error. Using spot urine is one of the contributing factor for the J-shaped findings. We published a paper, one in International Journal of Epidemiology, and another one in hypertension, and clearly show that this formula, this value, this like age, gender, sex, age, gender, height, weight, creatinine concentration, they all are important contributor to the J-shaped findings.
Okay.
That's only one of the factors. Another factor in lots of cohort studies, they included people who are not well, who are sick.
Uh-huh.
And this called reverse causation, because we know if you are not well, you can't eat, and then you have lower salt intake. And then because you're not well, you have a chronic disease, you are more likely to die. Mm. So the lower salt intake in these individuals is a consequence of their underlying disease. And it's not to cause, they call it reverse causation. So there's lots of problems with these J-shaped findings. And you can see our recent paper clearly showed, and different factors have contributed to the J-shaped findings. If you use accurate measurement of salt consumption, like we did, we analyzed the trials of hypertension prevention follow-up data. Actually, that study was done in the U.S., and we collaborated with researcher Professor Nancy Cook at Harvard University. And in the top follow-up study, and all of the participants have multiple non-consecutive 24 urine measured and measured salt intake. So if you look at this, salt intake, you can see there's a clear linear association. Okay. And so the lower the salt intake, the lower the risk of death. And down to a salt level is actually 3 grams per day. So there's no J-shape or U-shaped relationship.
There is none. Okay. What do you hope will happen as a result of your continuing work on this and your current published analysis?
Yeah, I'll continue. I hope definitely there's a clear message. Salt reduction is extremely beneficial for the whole population, not only in those with high blood pressure, but also with individuals with blood pressure in normal range. So firstly, and the general public need to be more salt aware and also reduce their salt intake. And for the clinicians, they need to give their patients appropriate advice on how to reduce their salt intake. Because, in our clinic, sometimes the patients come, they say, oh, my salt intake must be low because I never use salt in my cooking or at the table. But when you measure it, the salt intake is extremely high. This patient did not know, the food that they usually eat, like bread, breakfast cereal, are already very high in salt. So in most developed countries like the US, UK, and many developed countries, about 80% of salt in our diet is added to our food by the food industry. So for the food industry, they need to make a gradual and sustained reduction in the amount of salt they add to all of their food product. And the UK has been very successful in reducing the population salt intake. In 2003, we started this salt reduction program in collaboration with Food Standard Agency and also our group, Action on Salt. And what we did is to set incrementally lower salt target for over 85 categories of food.
Huh.
And the principle is a small reduction, but then you like 10 to 20% reduction, and then you repeat it at 2 to 3 years interval. And if you do it gradually, it's in a small reduction, and the general public wouldn't notice any difference in their taste.
Huh.
And they can continue to buy the food they usually buy. And their salt intake come down. And the UK salt reduction program has been really successful. From 2003 to 2011, salt intake in the population was reduced by 15%, from 9.5 grams per day in 2003 to 8.1 grams per day in 2011. So this, 15% reduction in population salt intake have led to a significant reduction in population blood pressure by 2.7 millimeters of mercury. And this was associated with a significant reduction in population mortality from stroke and ischemic heart disease.
I think we should all be reading labels more carefully when we buy food.
Definitely. For individuals in developing countries, it's important that when you do shopping, you choose lower salt option. And actually, no, there's an app available. You can use this app, and app scan the barcode, and then they will give you the lower salt option. And, tell you similar product, which one is high in salt, which one is low in salt.
What is the name of that app?
It's a salt app. Actually, there's a more comprehensive one called Food Switch. Food Switch.
Just a footnote here. Dr. He contacted me after our interview and wanted to be clear that she had misspoken about the name of one of the apps. They are Salt Switch and Food Switch, and I've included links to both on the website, podcasts.jwatch.org.
And this in the UK, Australia, and in China, India, and then lots of countries, this app are freely available for individuals to download. And then when you go shopping, you just scan this, and then we'll give you the traffic light. If you scan the barcode, it will give you the traffic light labeling. You tell one which one is healthier, which one is not healthy, and give you alternatives to buy.
Well, I want to thank you very much for talking with me today, Dr. He.
Thank you. Thank you very much. It's so good to talk to you.
That was our 255th episode. All of them are available free at podcasts.jwatch.org. We come to you from NEJM Journal Watch and the NEJM Group. The executive producer is Kristen Kelly, and I'm Joe Elia. Thank you for listening.